Good morning or good afternoon, good day, everybody. Thank you for joining us to this next Wellbeing of Women webinar. And on this day, we're going to be talking about, let's talk Hyperemesis Gravidarum. I'm very, very excited that we've got such wonderful panelists today. We've got some real experts in the field in obstetric medicine, Professor Catherine Nelson-Piercy and Professor Catherine Williamson, and Dr. Melanie Nana as well. They're going to introduce themselves. We're going to tell them a little bit more about their background as we go through to the question time. But what we particularly want to achieve out of this webinar is to help women understand who are joining us on this platform that we want to listen to the problems that they're having, that if they're a sufferer from Hyperemesis Gravidarum, there is help out there. It's not something that should be dismissed or sent away without help. And we want to effectively signpost you to where you can go for that help. So just a few housekeeping points. I think you're all very practiced now at doing these virtual meetings, but the webinar is being recorded and you can use the chat function to put in your comments and your questions. Feel free. What we will be doing is monitoring the comments and the questions, and then I will try to cover as many of them when we get to the point at which we can have some, when we can throw it open to the floor. And I'd like to say thank you to the Financial Services Compensation Scheme and to Bolt Burden Kemp, who have been supporting our webinar series. Every month when we have a webinar now, we are struck by how the platform becomes larger and larger and larger, and we get more and more feedback. So thank you to FFCS and Bolt Burden Kemp, because you're doing a great job and really promoting women's health. But I started off by saying that we wanted to understand and we wanted to demonstrate to women who are out there listening to this that we are listening. And you will remember that that is the core of the Women's Health Strategy for England. So in addition to being chair of Wellbeing of Women, the charity, I'm also the Women's Health Ambassador for England. And when we had the call for evidence in 2021, no less than 100,000 women responded to that call for evidence, talking about what it is that they wanted. And one of their major complaints was that over 84% of them told us that they hadn't been listened to or that their problems had been dismissed. And one of the ones that, one of the areas that they were particularly keen on, and it actually ranks second in the strategy document, are all the issues surrounding fertility and pregnancy complications and postnatal support. So I'm really, really thrilled that the Minister Caulfield, who has most of the women's health brief in her portfolio, has been so supportive about trying to ensure that we get something, where we better understand the issues of Hyperemesis Gravidarum, how many women are affected by this problem, and most importantly, demonstrate that we are listening to what they're saying and we want to help signpost them to services that can help them. So I'm going to now introduce you to our three fabulous panelists who have got lived experience of dealing with Hyperemesis Gravidarum. So who better to actually be telling us the story? And I'm just going to go through them one by one. And firstly, Rachael Buabeng, who suffered with Hyperemesis Gravidarum and runs a charity to support women from ethnic minority groups during pregnancy. So Rachael, can I turn to you now first, and please tell us about your journey, if you would. Thank you so much for coming and being brave enough to share all those, I'm sure, deeply painful emotions with the platform. There are now nearly 100 people on the platforms, and then the numbers keep going up. So thank you again.
Thank you so much. And I'm so glad that there are 100 people on this platform, because I talk to anybody that will listen to me about this condition just to raise awareness. So thank you for hosting us today. My name is Rachael Buabeng, and I have had hyperemesis 3 times. I have 2 children. So unfortunately, one of my experiences ended in a loss. And I think that alone was my first experience of HG, which shocked the life out of me, and I had no idea what this condition was. Along my journey of experiencing hyperemesis, initially I thought that suffering and just surviving as a woman through some of these challenges, as women sometimes do, was normal. And when I sought help from professionals, I didn't actually feel listened to, but what were they supposed to be listening to me about? Because I didn't really know about the condition. So whilst I was saying what my problems were, it wasn't really clear, and I didn't get a diagnosis initially. You know, as time went on, and I did get some medication for my sickness. So I'd been being sick. I'd suffered at home quite a bit, thinking that this is part of being a woman, part of having a child. I eventually got some medication given to me by a doctor, but no explanation. And as a Black woman, and as a woman from Black African heritage, there were things that we just don't do. You don't take medication when you're pregnant. You take paracetamol if you have pain, and that's it. And you just kind of plod on. And so whilst I was given medication, the lack of explanation meant that I didn't actually understand why I was given medication. That medication was anti-sickness tablets, but I thought sickness in pregnancy was normal. Okay. So as we've heard already, lots of women talk about not being listened to, and I was one of them. Finally, when I got the diagnosis of hyperemesis and had the education given to me about what the medication was for, I was able to navigate my next pregnancy a bit better, able to explain to my community what was happening to me, why I was so ill. And I found that as I was the only person that had this experience in my family and in my community, it was a challenge. I was trying to survive and explain to others what was happening, and taking on a role of basically sharing. I won't go into too much, but it was very challenging, and I was admitted into hospital several times due to dehydration and just becoming really unwell with my pregnancy. But by God's amazing grace, I was able to have these two beautiful children. And I then used my story to share with as many women and as many families. I have loads of partners contacting me saying, you're the only Black woman that I've ever heard talk about this. You're the only woman in the community that I've heard say there's something called hyperemesis. And actually, there's older women who've had their children, they're no longer in the birthing time, and they've contacted me and said, this thing that you're talking about is what I had. I just didn't know where to go. I didn't have no one to ask, or I told my doctor, they just sort of brushed me off. And I think that's quite interesting that a lot of us survivors have had to take on advocacy roles and be informants of this condition. And so my organization, which looks to bring Black and Asian women together to just socialize and validate and support and actually acknowledge the things that we're going through and let them know it's okay. From a culturally sensitive perspective, that's what I've been doing, and that's led on to several women come out and say, oh, I've had this condition, and we just hold space for them and tell them where to go and get help. And so that's how I've ended up on this call today, and I really appreciate you listening to me. And you know, whilst there's meds, whilst there's all this, there's other areas that we need to cover. The culturally sensitive approach, understanding people's backgrounds, in order to get them to the point where they're able to help themselves whilst we're helping them, is really paramount. So I'm running Mummy's Day Out and HD Support for All for those reasons.
Lovely. So thank you so much, Rachel. That's really helpful. And I'm going to now turn to Denisha Ramjas, who suffered with Hyperemesis Gravidarum in 2 pregnancies as well. So Denisha, tell us a little bit about your experience.
Hi, my name is Denisha Ramjas. So I was a patient with hyperemesis, and I've had hyperemesis twice now. Now in my 2nd pregnancy, and I'm also on medication for hyperemesis again. I'm also a GP trainee, so I'm also a doctor myself. And I think what was interesting for me is kind of my experience, even though I knew about the condition as a pregnant woman for the first time, still feeling hesitant to kind of what was normal and how much I should be seeking help, even though I knew there was help out there. And I think it's kind of brought to light for me how important it is for GPs to be educated about hyperemesis. And like most doctors who are quite afraid to treat pregnant women with medications, especially in general practice, just knowing that there are medications that are safe, that are out there, and that we can advocate for them. And women shouldn't be afraid to ask for help when it comes to severe nausea, vomiting in pregnancy. I was extremely fortunate in my pregnancies because I was able to access help easily and advocate for myself, but I do understand that it's not so easy for others. And it has definitely inspired my future practice to make sure that I do make sure that I also, within the GP community, try to promote more education and training in especially about this condition.
Thank you. That's a really helpful insight. And I was just reflecting when you said that I remember when I was pregnant with my twins, which is a very, very long time ago, how I was in a total panic because I knew an awful lot about obstetrics and gynecology, but I knew nothing about being a pregnant mother. And I kept saying to the people who had the miserable job of looking after me, please tell me what to do. I don't know what to do. So I think that's so important that we all remember as healthcare professionals that it doesn't matter what, the woman is standing in front of you, what experience she's had in the past, you need to make sure she understands what she can do to help herself. Now, I'm going to move on to Charlotte Howden, who's the current chairperson of the Pregnancy Sickness Support Charity. And she's going to tell us, I think, a little bit about what it's like to be bedbound and to not be able to function, and how the charity that you're chairing can help support women. So, Charlotte, over to you. And then I'm going to turn to our three wonderful experts, and they're going to tackle individual or rather separate areas of this whole problem. So hopefully we give all those people on the platform some really good information. Oh, there's now 105 people on the platform. So the numbers are going up. By past, we'll have maybe 150. Right, so Charlotte, over to you. Thank you.
Thank you. And again, just to echo what's already been said, great numbers to see that on this webinar. Look, my personal story is what has led me to, I was chairperson of Pregnancy Sickness Support. I'm now the CEO, which is a very new appointment. So, and my personal story is similar to what many sufferers will say, that the beginning of that what is supposed to be a glowing moment in your female journey, I suppose, of being pregnant, and it was not that at all. Very similar, bedbound, a lot of vomiting throughout the day, nausea. I feel like I'm saying this all the time, but it's all very, very similar, that we go through this experience really not understanding what's happening to us, and not being believed, which is obviously what was mentioned at the beginning of this this webinar. And I think most sufferers that we speak to at the charity would agree with that, and it's all a very similar experience. So, but hopefully what I can say today is that there is support out there, and there are resources out there. Pregnancy Sickness Support has been operating now for over 20 years, which is incredible. It's a lifeline for many, many sufferers. We have grown and evolved, and I really want any sufferers on the call today to know that the resources we have, so whether you're unable to call our helpline because talking might be difficult for you, perhaps you prefer WhatsApp, perhaps you want to contact us via social media, we are extremely accessible from a communication point of view. We can guide you with help and guidance on treatment, how you may approach primary care practitioners and secondary care who may be struggling to understand what you're trying to say, who may not have dealt with someone who's had hyperemesis before. So we have all that support there available. I think our biggest USP, which I really love to shout about, is our peer support network. So what's fantastic about that for any sufferer is the ability to talk to someone else who has been through what you've been through, who has walked a couple of miles in your shoes. And it's a fantastic network that we have, which is all supported by our volunteers. We have an incredible network of volunteers. So there's definitely support out there. And just finally, really, as I've talked to, hopefully spoken to the sufferers, we are there also for clinicians, healthcare professionals. Please do reach out. We are there to support you as well with evidence that we have, research that we've been involved with, lived experience, and training as well. So please, it's not just for the sufferers. Any healthcare professionals, please do get in touch.
Lovely. Thank you very much, Charlotte. And we'll obviously when we circulate the recording of this, we'll obviously circulate the website, but you might want to just pop it into the chat now for anyone who's looking. They may not be able to wait for 24 hours to get to it. We've got midwives and consultant obstetricians and academics all saying in the chat, you know, I don't know necessarily an awful lot about this, so I'm very pleased to be here. So there we are. The link is up there in the chat. Now, I'm going to turn to our experts, and I feel very privileged because we've got some really, really fabulous experts here. And I'm going to first turn to Catherine Williamson, who's going to give us a little bit of background about the definition and the pathophysiology of Hyperemesis gravidarum. So, Kath, if you'd like to just introduce yourself, and then I'm going to ask you, what is Hyperemesis gravidarum? So I'm giving you a bit of a lead moment to think about that. And then we'll go on to ask you about what the causes are, if we understand them, and how common it is, and perhaps a little bit then about the genomics and the bioresource. But I'll prompt you again. So, Kath, over to you. Thank you so much for joining us today.
Thank you so much for inviting me. My name's Catherine Williamson. I'm Professor of Women's Health at Imperial. I'm an obstetric physician, so have worked with and managed many women with HG over the years. I've worked very closely with Catherine Nelson-Piercy, who's going to speak later. We collaborate a lot. We're interested in hearing women who, as you've heard, don't always feel they're heard, and finding ways to treat women and make sure we have better outcomes. So in terms of your first question, what is Hyperemesis gravidarum? Essentially, it is very severe nausea and vomiting in pregnancy. A couple of years ago, there was a consensus definition decided at a meeting in Windsor. So essentially, I would think of women as presenting before 16 weeks in pregnancy, having either nausea and vomiting that are very severe, limit their daily activities, and an inability to eat and drink normally. So, and you will hear this from the lived experience and from many of the people we've seen. It can have a major impact on daily activities, and is relatively common, affecting somewhere between 1% and 3% of pregnant women, and about 1 in 5 have symptoms throughout the whole of pregnancy, not just in the first trimester.
Lovely, thanks, Kath. So what are the causes? I know that's that's almost like an embarrassing question to throw at you, but have a stab, please.
Well, the causes, it's not a simple condition, as with, I'm sure, many of the conditions you've talked about in the webinars. You could call it multifactorial. There are a lot of conditions that cause an endpoint of HG. I actually have a couple of slides I could talk through to show people. If you're not scientific, please don't worry about the graphs. I'll talk about them in normal terms as well. So there are a small number of people with HG that have underlying conditions that make them more susceptible. Most commonly either hormone conditions or gut conditions, but there can be a number. And some people have something called trophoblastic disease. You might have heard of molar pregnancy, where essentially there are more placenta hormones, and they seem to get it more commonly. But most people with HG are fine when they're not pregnant, and then when they're pregnant, they have these terrible symptoms of HG. And for many of these cases, genetic factors are of relevance. We knew this before some of the lovely work that I can tell you about today, because the sisters, the mothers, the daughters of women with HG more commonly have HG. And also it seems to come back in every pregnancy, which really does suggest an underlying susceptibility. So there have been some lovely pieces of work done recently. The most influential genetic study was done by somebody called Marlene Feijó from the States, who actually had HG very severely in her pregnancies. She's a stellar scientist, and she did a very clever thing. She worked with the company 23andMe, who collect genetic information from the population, and they included a question about whether people vomited in pregnancy. And she was able to study their genetic data in big, sort of large-scale genetic studies. And she found 2 very interesting hits. One of them related to a hormone, which is called GDF15, and another was the hormone receptor in the brain. So that was of great relevance. There were other hits as well, but the one where there's been more work done and it looks very interesting is GDF15. There's a team actually in the UK that are world leaders on this, led by Steve O'Reilly in Cambridge, and they've done some lovely work, and I've summarised some of that in the graphs that are shown on this slide. The blue labels represent people who don't have HG, and the green, people who do. And at the simplest level, the first graph you can see with the two boxes, there are higher levels of GDF15 in people with HG. In the right-hand graph, they show people in early pregnancy, week by week, what the concentrations are. And again, you can see the green bars and dots are higher, so showing that women with HG have more GDF15. So I'll just tell you a little bit about what GDF15 is. And again, you don't have to be a scientist. You could ignore the science parts if you haven't trained in science or medicine. But essentially, GDF15, it has just one receptor protein in one part of the brain. And I think it plays an important role in our responses of aversion to certain things. So it can cause people to have nausea, vomiting, and every person I imagine listening can remember something in their life that they have eaten or drunk and they can never bear to touch it again. And almost looking at it makes them feel sick. Now, I think this is probably something that has protected us through evolution, but also it's now known that GDF15 and its receptor help to mediate this. And so it's a very good candidate for something that could be of relevance to HG. And the two groups I've told you about are doing some very lovely work now where they're showing ways that may explain why some women are genetically more predisposed to HG because of changes in GDF15. It's not the whole story, but I think it's a part of the story, and it could be of relevance for maybe finding new treatments as well.
Lovely, thank you so much.
More, if you would like me to, Leslie.
No, that's absolutely lovely, and I love a picture. I think a picture speaks 1,000 words, doesn't it? So thank you. And how common is the problem, Kath? Because I'm sure everyone's going to be asking that question in the chat very soon.
Well, HG, it affects around about 1 to 3% of pregnant women, so it is not uncommon. Excuse me, and as I said earlier, about 1 in 5 of them will remain sick throughout the whole of pregnancy. So it recurs. So to some of us, it maybe feels commoner because women who can bear to have another pregnancy, and I'm sure Melanie will say more about that later, we will see them again.
Lovely, thank you. And you know, just if you think 1 to 3% is a small number for the non-scientists, it's actually quite a large number. So I think I'm right in saying that 3% is similar to the incidence of diabetes in the country, isn't it?
Yeah.
Okay, so any comments that you want to make about the genomics, or I think you've covered those with the GDL15. I've been scribbling notes here. I've just had a wonderful tutorial, so thank you for that. So
that's one thing I would love to say, actually. If anybody has HG that has been severe or it runs in their family and they would like to take part, we've been funded by the NIHR, which is the research arm of the NHS, to do genetic studies. Now, I think GDF15 is a really important finding, but I am certain from what we've done with other similar conditions, there are other genes out there we can learn more. So if anyone is interested, please be in touch and we will be delighted to include you.
Great. So your suffering can actually help others if you contribute to the research. So that's fabulous. Now I'm going to move on to Melanie Nana, who is an obstetric medicine registrar and an NIHR clinical research fellow at King's. And she's going to be talking about it. I know, as I've had many conversations with her in the past, she's absolutely passionate about this and her research project. So Melanie, over to you. I wanted you, if you could talk to us a little bit about the physical and the mental health complications of hyperemesis gravidarum. So starting off with the physical complications.
Well, so I think historically hyperemesis has been defined as vomiting or nausea that is severe enough to cause a woman to become dehydrated, to lose weight, or to get abnormal salts in the blood. And that's why it is the leading cause of hospital admission in the first trimester of pregnancy, because often women will need to be admitted to hospital to have a drip of fluids, to be given anti-sickness drugs through a drip. And so I think they're the things that are most commonly recognised, but we also recognise that these women are at increased risk of getting clots in either the leg or the lung because they're immobile, and we know that pregnancy increases the risk anyway, and combined with that and the vomiting and the dehydration. And very rarely women can run into trouble with low vitamin levels, for example, vitamin B1 level, which can affect the way that the brain works. And the salt levels becoming so low that it can affect sometimes, and very rarely, the working of the heart. So I think clinicians that are looking after women who have hyperemesis, as a reassurance factor, we know that when a patient comes in, that if they're very dehydrated, we need to check the salt levels, and we need to make sure that we give extra vitamins so that those complications don't happen. So they're the things that I think are quite well recognised. But I was very fortunate when I first moved from Wales to London to work with Professor Williamson and Professor Nelson-Piercy, that we undertook a study where we wanted to learn about the lived experience of women across the UK. And I'm an endocrinologist by background, so also didn't know that much about hyperemesis at the time, but had the wonderful opportunity of, we sent out a survey through with the help of the BBC and Pregnancy Sickness Support. And in a very short period of time, over 5,000 women across the UK replied and told us their story. So I will share, if it's okay, just the main findings of that, which are the reason that I now am doing a PhD in hyperemesis. So if you can see that screen, 5,000 women from 14 different UK regions shared their story. And there were questions that said, have you suffered with hyperemesis before? When does your vomiting start? Have you had medications? And there were two questions that really struck us. So one was, have you terminated a wanted pregnancy because of this disease? And one was, have you experienced any suicidal ideation? And as a clinician coming from a medical background, I was really startled by the fact that women were going through what I had thought was a part of a reasonably normal pregnancy, but were terminating pregnancies for that reason. So when we found these findings, we looked further into the study to try and understand why those women were being led to make these adverse outcomes. And as might be expected, women who had more severe disease, so women who are vomiting 10, 20, 30 plus times a day, would be more likely. Those, as Charlotte mentioned, who had a very poor quality of life because of functional status. So 70% of these women can't get out of bed during their pregnancy. That means they can't look after their children, they can't hold down their job, they can't meet their friends and family. And then the third was that they were unable to access medication, and that a perception of the care that we were providing in primary and secondary care was poor. And I think as a clinician, there's certain things, as Prof Williamson said, we don't know all about hyperemesis, but we can be kind and we can listen to patients. And this was something that we wanted to understand more about. So in the survey at the bottom, there was an open box feedback area where women could write their story. And I think typically in surveys I've done before, maybe 20% might write a message to say this was my experience. But out of 5,071 patients, over 5,000 women wrote their experience in that box. And we therefore felt that we would only do justice to those women if we carried out an analysis where we could draw the main themes. And with your permission, I'll share some of those themes that I think summarize what we feel that we see in clinic as well. So the way that we do this is we look at we read all of those 5,000 comments, and then we say, these are the comments that come up repeatedly, and this is a representative quote. And it makes for a hard read. And so I'm grateful, Charlotte, that we're sharing the charity support line, because I think that this is something that will resonate with lots of patients who have this disease. So firstly, the physical health. So over 1,000 women wrote that they had lost so much weight that they were able to see bones protruding through their body. They weren't able to eat enough to what they thought would be helpful for a healthy pregnancy. And that leads on to some of our research that Wellbeing are very kindly supporting. The second is termination of pregnancy. So women saying, I could not take it anymore, and asked for termination as I had nothing left. So 200 women said that. And then 65 women saying, I felt scared and alone and attempted suicide when I felt like there was no way out. And I think a lot of this comes from the fact that we do not hear these women's voices, and so the support isn't available. Over 1,000 women felt that they hadn't been listened to. And I know you mentioned the women's health strategy and that remarkable number of women who don't feel like they are heard. So I wasn't taken seriously until I'd lost 2 stone, or been made to feel like another mum unable to cope. And Denisha mentions her experience as a GP of first pregnancy, but I think, you know, there are many complicating factors that can make this more difficult. And if a woman doesn't feel guilty about taking these medications, as Rachael mentioned, the culturally and family and thoughts about safety can also make it difficult for women to seek help. So 135 women mentioned concerns about pregnancy. This lady had taken it and had a baby who was born with an abnormality and blames herself. But I think what we need to recognise is that 3% of the background patients will have a baby with some form of abnormality, and we need to be confident in telling them that these medications are safe and so that they don't carry this guilt if they have an abnormal pregnancy. Clinical inertia, which I know is a huge problem, and we're trying to do lots of education, so we are grateful to be here today to talk about this, but being told that it's safer to persevere with these symptoms and risks than it is to take a medication which has got a very good evidence base. And then finally, being sterilised because the thought of another pregnancy is awful. And these are women who plan to have a family of 2 or 3, ideally, who are choosing, and we're told in clinic, I cannot go through this again, I need to be referred for sterilisation. So I'll stop there, but I think that when we focus on HG care now, we need to have a big understanding of not only the physical complications, but the other ways that women need to seek help.
Thank you very much, Melanie. That's lovely. So we've got the physical and the very, very shocking mental health data that you've collected from your survey, which I remember I got very excited about when I read it in the American Journal. So thank you for that. Could you just like to mention Wellbeing of Women have funded you to look at nutrient status. Do you want to make a few comments about that before I pass over to Catherine Nelson-Piercy?
Yes, so I was very grateful when I was starting out on this. Once I'd done that survey, it felt imperative that that was what I was going to do in terms of research. And one of the questions that came up in those open box feedback is, am I eating enough, or is the amount of weight that I'm losing safe for my baby? Are they getting the nutrients they need or not? And the other thing is that we were finding that when we're talking to healthcare professionals, they say, but it's a benign disease, so actually it doesn't really matter. This disease won't cause any harm in the long term, so, you know, push on. So I was tasked with going to the literature to try and find out what the nutrient levels are in women who have this disease. And as we often find in women's health, I went back through all of the literature that had ever been published and found one study. There was one study that had looked at the actual blood levels of nutrients, and half of them were low, but we don't know what it means because no one followed the study up. So you and Wellbeing kindly put out a call for research, and we applied as a group and have looked at the nutrient levels of 70 women so far, and compared them with the women who haven't got the disease. And we haven't published the results of that yet, but we will do very soon, and they are very interesting. So the purpose of my PhD taking on from that is to find out if the nutrients are low, what does that mean for the mother, and what does it mean for the baby? Because only then it will become clinically relevant. And if we find that there are a group of nutrients that cause worse outcomes for the mum or the baby, we can think in the next 5 years about trying to think of treatments that could replace them.
Thank you. And just while we're on that point, for women who've gone into hospital and have had to have intravenous fluids and replacement of minerals and vitamins and supplements, do you want to just quickly make a comment about that? Because if there's someone who's just getting an ordinary dextrose or saline drip, they perhaps need to prod people that actually I need some additional things added to this.
Yeah, so I think in terms of the treatment in hospital, IV fluids are important. We know that the salt levels in the bloods are important. So we would expect that a patient that was being admitted for fluids would have a check of their sodium level, their potassium level, because it's the potassium that most frequently needs replacing. And then in terms of the vitamins, we know that the women's B1 level can be low, and all of those treatments and everywhere we have got an evidence base are in the literature, are in the guidelines, and they will be in the upcoming guidelines too. So treatment.
I'm so pleased about the guidelines coming out, because when Catherine Nelson-Piercy told me that it was being held up again, I sort of threw a bit of a tantrum as an ex-president of the RCOG, said, what's going on here? We've actually got to stop this. You know, it's going to be the generation, it's going to be the gestation of an elephant, these guidelines, if we carry on like this. And I think it's coming out quite soon, isn't it? And with that, I'm going to pass over to Catherine Nelson-Piercy, who's going to introduce herself and tell us a little bit about management and these very important guidelines, which we're all awaiting.
Thank you very much for inviting me to take part in this. Like Cath Williamson, I am an obstetric physician. I work at St Thomas's, so I look after women with all different sorts of medical problems in pregnancy, and I've done that for 28 years. So I've had a lot of experience of looking after women with hyperemesis. In fact, one of the first studies I ever published when I was a registrar was a randomized controlled trial of steroids versus placebo for hyperemesis. So I've had a lifelong interest in this condition. And more recently, I'm now the lead for the updated RCOG Green Top Guideline on nausea, vomiting, and hyperemesis. I would like to say it's out, but I can't. It's been to the final guidelines committee meeting, and I think they've approved it. And I'm going to put my neck out and say it'll be out by the end of the year, Lesley, but you have far more influence than I do to actually make it happen. But we're nearly there.
Happen.
we're nearly there. There was a previous guideline. There has been a guideline since 2015, 2016. So having a guideline isn't enough. So running webinars like this and educating, the guideline is really, as you know, Lesley, aimed towards obstetricians and gynecologists. What's new about the next guideline is, thanks to Melanie's help, we've been able to write an algorithm that addresses specifically GPs, specifically emergency departments, specifically early pregnancy units, as well as the inpatient management, because the focus is slightly different depending on where women present for their care. And these algorithms are one page. That's all that the doctor has to read, one page, and follow it. So hopefully it will make it easier, because reading through a 40-page guideline is really boring and not very helpful. And what you want is a ready reference to educate everyone.
Lovely. Thank you very much indeed. So do you want to tell us a little bit about medications now?
Yes, I think Melanie's going to kindly share a slide for me. So hyperemesis is treatable. And this is what the new guideline will say. So I'll get into lots of trouble if you all start screenshotting this. So please don't, because it's not published yet. But what I want to say about this is first of all, we've added Zomvia, which is doxylamine and pyridoxine. I saw there was a question in the chat, Lesley, about Zomvia. So this has been given to 30 million women in the world. It's the first line treatment in America, Canada, Spain, and Chile, and yet it's only recently been available in the UK. For those of you that are as old as me, Zomvia is what used to be called Diclectin or Devendox. It's the same drug, it's doxylamine. It's a very, very old drug. And it's in the same class as histamine blockers as cyclizine, prochlorperazine, which is Stemetil, promethazine and chlorpromazine. All these are antihistamine drugs, and they all are used to treat nausea and vomiting in pregnancy. Most evidence actually exists for Zomvia, which is why it's been added to the new version of the guideline, because it's now available. It's not available everywhere, and I've been reading the comments in the chat. It depends where you live in the country as to whether your GP can prescribe this, or even whether your hospital doctor can prescribe it. But it can be prescribed privately, which is what one of the women in the chat has said. That's ridiculous. That's postcode lottery, and we need to get this drug available everywhere. But it works. But many women with hyperemesis, one drug isn't enough, and they need two drugs. And the first thing I want to say is that if one is working a little bit, but not completely, then it makes absolutely no sense to take that one drug away and give another one. You have to add in a second drug. And the second line drugs are metoclopramide, domperidone, which both work in a similar way, and ondansetron. And I'm going to talk a little bit more about ondansetron in a minute, because there's so much bad press with ondansetron. I'm going to, with your permission, Lesley, use this platform to educate people that it's not as dangerous as people think. And for women who fail to respond to intravenous fluids, hospital admission, at least two or three drugs given intravenously regularly, if they're still suffering, and that's a very small proportion of women, but they do exist, then we use steroids. And that comes back to the first study I did. And steroids work, not for everybody. But the issue about this stepwise treatment of hyperemesis is you need to use the drug regularly. You need to start early. There is evidence for preemptive use of Zomvia. So women like Rachael and Denisha, who've had it before, we will often recommend that those women start their sickness tablets when they're pregnant, not when they start vomiting and can't swallow the tablets anymore. That's called preemptive management, and that works. But you need to give regular anti-sickness tablets. You might need to give 2 or 3 in combination. You might, for the most severe cases, need to give them intravenously or intramuscularly as an injection. And you need to continue them. This isn't a course of antibiotics. You give a course of anti-sickness tablets and the woman's cured. No, you need to continue the anti-sickness tablets until such time as that woman that woman's hyperemesis would have got better naturally. So one of the first questions I always ask my patients is, when did it get better last time? Because history repeats itself. If you're unfortunate enough to have it all the way through pregnancy, then that's going to happen again. If it gets better at 16 weeks, then that's what it's likely to do second time. So you need to continue the drugs until the time that the vomiting goes and the nausea goes. And on that note, Lesley, vomiting is not the worst symptom. What women with hyperemesis tell us repeatedly is they can deal with the vomiting. What they cannot deal with is the constant nausea. But the vomiting is sometimes a relief. The nausea is constant, wakes them from sleep and clouds their whole day. And, you know, the first element of management should be listen to the patient, validate her symptoms. And then in order to get our patients to take 1 drug, 2 drugs, 3 drugs, that needs a trusting doctor-patient relationship, because as Rachael has said, you've got so many influences telling us. I mean, biologically, I've been pregnant. The last thing in the world I wanted to do when I was pregnant and had sinusitis was take any drugs. I had to go and ask another doctor, could I take this drug? Because I wasn't sure. I wanted, like you, Lesley, I wanted someone else to tell me what to do. So, but when women trust us, they will take the medications. And for the vast majority of women, the medications make things better. I'll just talk a little bit about ondansetron. I think that's on the next slide, Melanie. So ondansetron is a very good drug. It's the first line drug used for vomiting associated with chemotherapy. And if you have friends or relatives who've had breast cancer, they have chemotherapy, they're given ondansetron and steroids to help the vomiting that you get with chemotherapy. It's what we use post-surgical operations. Women, men are given ondansetron. It's a very effective drug. There was one systematic review that showed that ondansetron increased the risk of cleft lip and cleft palate. And because of that review, the MHRA put out a warning, which undid 20 years of work that the rest of us were doing to try and get drugs prescribed. But as Melanie said and Kath said, the background risk of congenital malformations for all women who are pregnant is 3%. 3 in 100 babies born to all women will have some form of congenital abnormality, much higher than people realize. And of those 3%, roughly 11 per 10,000 will have a baby with a cleft lip or a cleft palate. And what this study showed was that if you take ondansetron in the first trimester, then the risk of cleft lip or cleft palate goes up to 14 per 10,000, which means that the attributable risk of ondansetron is only 3 per 10,000. And it was only shown in 1 out of 3 systematic reviews. So it may be that ondansetron taken in the first trimester increases your risk of cleft lip or cleft palate by a tiny amount, 3 per 10,000. But that's not a reason not to take it if ondansetron cures your vomiting and you're able to eat. Because what I think Melanie's research will show is that if you become deficient in a lot of vitamins and you lose a lot of weight and you're basically malnourished, that can impact on the baby's risk of malformations and the baby's growth and all those other mental health aspects that Melanie spoke about. So the message really is the drugs work. You need to take the drugs regularly. You need to be given them early. And any GP who says, oh, just get on with it, it'll go, or no, I can't give you this one, it's dangerous. That's when to take a copy of the guideline and say, but look, this RCOG guideline says use these drugs.
Great, that's really helpful. And something about thiamine and PPIs and laxatives and all those other things?
Yes, so we've added, so that I've been batting on about the anti-sickness drugs, but the management of hyperemesis involves intravenous fluids, anti-sickness drugs, and thiamine, which is vitamin B1 that Melanie spoke about, because deficiency in thiamine, which is what happens if you starve, and what happens also in alcoholics, leads to a very rare condition called Wernicke's encephalopathy, which is treated with thiamine and can make women and men very, very ill indeed. So any woman admitted with hyperemesis, we give her thiamine, usually intravenously in the form of a multivitamin complex, because most women admitted with hyperemesis haven't eaten anything for 1, 2, 3, sometimes 6 weeks. They are severely malnourished. So the first thing we do before we give them any anti-sickness tablets or any glucose-containing fluids, which we try and avoid anyway, is to replace their thiamine.
Lovely.
Something else. Oh, PPI, yes. So PPI stands for protein pump inhibitors, which is what a lot of pregnant women will complain of reflux. Patients, women with hyperemesis, their reflux is worse because they're not getting food in their stomach, so all they get in their stomach is acid. So this makes the nausea worse because they just regurgitate this horrible acid. If we give them anti-acid medications, which is drugs like omeprazole, that gets rid of the reflux, which in turn helps their symptoms. For women who we treat with steroids, we always co-prescribe a PPI with it.
And then from a very practical point of view, the laxatives.
Absolutely. So ondansetron causes constipation. Very few drugs are without any side effects, and all the women, all the sufferers are smiling because any woman who's had ondansetron will know that it causes constipation. I have one woman who said, I'd rather deal with the nausea than the constipation, which was quite shocking. But so when we prescribe ondansetron, we co-prescribe it with copious amounts of laxatives. And that brings me to iron. We stop iron replacements because the combination of pregnancy, iron, ondansetron, you're not going to have your bowels open for 2 weeks like that. And that's not nice either.
No, it's absolutely miserable. My little tip to everyone is you need to get into the habit of eating all bran mixed up with yogurt in the morning so it doesn't taste quite so dry and horrible. And it just needs to be part of your daily life. Okay, so now whilst you're in hospital or you're absolutely bedbound, what are the other things that we've got to watch out for, Kath? Because I think women are at a greater risk of venous thrombotic events, aren't they? So are they
definitely are, yeah. And I would say if a woman is admitted to hospital and bedbound, she should be having treatments to protect against clot, definitely. The other thing, as Melanie mentioned, is the salts in the blood, the electrolytes, particularly sodium and potassium, because they can become critically low to put women at risk of heart problems and even a cardiac arrest. So it's very, very important that they're watched as well.
Okay, well, that's really, I think you'll all agree, has been a very comprehensive whistle-stop tour of what can be done following our fabulous panelists who had the lived experience. Just one point, home IV fluids, is that a reality now?
Yes, so again, there's a bit of a postcode lottery, but most hospitals will offer a hospital at home. It's often used for cancer patients or palliative care, but it's the same nurses who deliver it, and it keeps women out of hospital. No woman wants to be in hospital. She wants to be at home, and where it is available, it is used, and it's part of the guideline as well to offer outpatient treatment first. So outpatient, either visiting the hospital, getting IV fluids, or the hospital coming to you and giving you IV fluids, and that's much nicer. Women prefer that.
Yeah, great. Now, Andrea Woolner said, great to hear about Zonvia being included, but it's not approved on the Scottish Medicine Consortium, and the RCOG guideline will help. Yes, and I can also tell you, Andrea, that I'm actually this afternoon meeting up with the Women's Health Ambassador for Scotland, so I will mention that to her and see what we can do. I mean, never miss an opportunity to try and change things. Now, I'm going to go back to a question that I heard earlier from, I think it was from Varsha Jain. Been told by a diabetes dietitian that HG is linked with progesterone levels in the body and that there are peaks of symptoms at 32, 34, 36 weeks in line with progesterone peaks. And her question is, are there known links with progesterone sensitivity and hyperemesis? And are women with hyperemesis at greater risk of GDM?
Kath, do you want to take this?
I think it's a very interesting question. more work needs to be done to be certain. What I can tell you, the genomic studies, I couldn't go into all of the details. One of the other so-called hits relates to progesterone, and we think this will be a very interesting thing to look at, and it's something we're planning to do over the next few months. Some of the work Melanie's doing, all the samples we're collecting, we will do hormone studies as well. Another interesting anecdotal point is when I've spoken at times about HG to different groups, women have mentioned that they had cyclical nausea. A subgroup of women who've had HG also at some stages in their cycle had similar symptoms, and it does seem to coincide with the stages of the cycle where progesterone is a bit higher. So I think it's an interesting thing that was raised. I think more work needs to be done. We and others will aim to do it in a rigorous manner where we can have a real answer. So I hope in a few years we can tell you more. In terms of GDM, again, with Melanie, we're hoping to look at this properly over the next couple of years, and Wellbeing have helped us set up the studies to be able to do that. It's tricky in that if a woman is not able to eat, her susceptibility to GDM is probably reduced, but we'll try to give clear messages soon. Kathy or Melanie, would you want to add to that about GDM?
No, only to say that I think women sometimes play catch up, so they eat nothing for the first 20 weeks, and then they've lost a lot of weight, and they think, right, okay, I can eat. And we say to them, eat whatever you want. You know, we don't say you must follow a healthy diet. we're just so pleased they can eat anything. And I do think there might be, hopefully that the genetic studies might show a link, or it might be shared risk factors. But I think it's also to do with the fact that women with hyperemesis tend to eat, people talk about a very beige diet, a very bland diet, and often the only thing they can tolerate is plain rice, you know, and it's not a particularly salad and fruit and Mediterranean diet that these women eat. They eat whatever they can keep down, and that is not necessarily healthy stuff. And so, yes, I can see why there might be a link with hyperemesis and subsequent. We've certainly looked after many patients who eat nothing for 20 weeks and then develop gestational diabetes. Whether it's real or just anecdotal, I'm not sure, but I can certainly believe how it would happen.
Right, well, that's really helpful. So thank you very much indeed for that. And it's also exciting that all of this research is going on in these studies. So I'm sure that our platform will be saying, voting with their feet and asking us to have a repeat session in a year's time, say, and that, because that would be lovely. Now, I'm just going to turn, in the last few moments, I'm going to turn back to our three lived experience panelists and ask them if there are any comments that they would like to make. So let me just start with Denisha. Denisha, anything further you'd like to add, having listened to our experts and having sort of, as I've been doing, skimming the questions. There's so many of them and I can't ask them all, but we promise you that any specific issues and all of the contact details for the various individuals who have been our experts here today and their research projects, we will send those to you along with the recording tomorrow, so that a lot of people have been asking how do they get hold of, how can they join studies, so we'll make sure that you've got all that, so don't worry about that. So Denisha, over to you, and then I'll come back to Rachel, and then just one last word from Charlotte.
I just had a few things to add. I have participated in one of Prof Williamson's genetic studies, so I definitely encourage anyone who's suffering from HD to definitely volunteer to participate and help improve treatments for future sufferers as well. The other thing is I would also encourage patients to definitely see your GP if you are having severe symptoms. You know, even if they don't know about it, try to push it as much as you can. Try to tell them that there are guidelines out there to guide them, and don't be afraid to question if they try to turn you away. Do try to be perseverant. No, you shouldn't have to be, but do try to persevere, because there is help and it makes a huge difference to being able to live your everyday life, carry on going to work, not have to be off sick, all of the things that affect your everyday life. So I would definitely say that. And I will also do my best to try and improve GP education, at least for my cohort.
Okay, Rachel, just a one-liner from you, please.
Your mental health matters. It does affect your mental health. Get the support, speak to someone, and don't suffer in silence. And thank you for the new guidance. It's game-changing.
And I was just about to say, in response to Denisha and Rachel's points, that, you know, you can always contact one of us, and you can be, when the guidelines have come out, and we can give you access to that so that you could take that along to your GP. I mean, if you handle your GP who saying, oh, well, why don't you know about this? They may not be nearly so helpful as if to say, look, someone's very helpfully given me this guidance. Can I share it with you? Is there anything you think in this guideline will possibly help me? You know, the art of changing hearts and minds is key, isn't it, in negotiating? So, Charlotte, over to you.
Yeah, finally, just to pick up, this is obviously a very physical condition, but it does also affect our mental health, and pregnancy sickness support do have an HD counselling service, and we have fully funded and part funded sessions available. So if you have suffered, are suffering, please do get in contact if you want someone to talk to, because we are listening.
Lovely. Well, thank you very much. So with that, I'm going to wrap up now. I just want to say thank you very much indeed to our three ladies with lived experience, and similarly to our three experts who've done a fabulous job of really giving us the most up-to-date tutorial. We will be asking you back, experts, I think, for the future, because I'd love to know what's happened with Melanie's studies and the further genomic work. That'd be really exciting. And I'd also like to give a shout out to Wellbeing of Women, because I think it's really valuable that not only do they raise money to fund research into every other part of women's health, and also have an education and advocacy pillars to their strategy. But as you will have heard from Melanie, we're also very, very interested in funding the training for young people to come through as researchers, both doctors and other healthcare professionals, midwives, nurses, because you can have all the money in the world and all the research ideas, but if you don't have the individuals who are passionate and committed enough to carry out the research, then we never make any progress. So please think about contributing to Wellbeing of Women and supporting us. You can go onto the website, you can do all sorts of things to participate. You can find a whole wealth of YouTube webinars that we've been running ever since COVID started, and you may well find that there are some that really interest you as well, after you've overcome your Hyperemesis Gravidarum. So thank you again to everybody. Thank you to the Wellbeing team for arranging it all to work so smoothly. And I really hope that I see you again in the future on another one of our webinars. So thank you very much, and goodbye for today. Bye-bye.